Hi. So I'm so delighted to meet you in this program JIP's Horse and Hot News. Yesterday, we received a patient who presented with fever, body pain and dry cough for past 5 days. We couldn't make much auscultatory signs. When patient was subjected to chest x-ray through patchy infiltration across both the lungs. So we are seriously suspecting atypical pneumonia. So you are all aware that community acquired pneumonia is almost caused by Streptococcus pneumonia. Then 20% of community acquired pneumonia is contributed by atypical bacteria, namely Legionella pneumonia and Chlamydia, Mycoplasma pneumonia and Coxiella psittaci and so on. This atypical bacteria, it is very difficult to detect by means of laboratory investigation. So generally, why we call it as atypical bacteria? First, most important, it doesn't contain bacterial cell wall. So they won't respond to beta-lactam antibiotic because beta-lactam antibiotic kills bacteria by interfering with bacterial cell wall synthesis. That's the reason if you suspect atypical bacteria, then probably you have to give macrolides, preferably azithromycin or doxycycline or respiratory quinolones, something like levofloxacin. But here, the peculiar features of atypical bacteria, they won't have any cell wall. And second one, you can't detect by means of Gram stain. And third one, it is very difficult to culture. So because of these reasons, generally the clinical suspicion should be very high. So when you will suspect atypical pneumonias, generally in atypical pneumonia, rather than the pulmonary symptoms, they will have more constitutional symptoms like fever, body pain and loss of appetite for 5 to 7 days. Then apart from that, they will have extra pulmonary symptoms. For example, Mycoplasma pneumonia, they will have erythema nodosum and erythema multiforme. Even they will have aseptic meningitis. There are few reports Mycoplasma pneumonia have precipitated GBS syndrome, Guillain-Barré syndrome, and even sometimes ataxia, cerebral ataxia, and so on. Likewise, in Legionella pneumonia, 40% of the patient will have diarrhea. So, because of these reasons, it is very difficult to suspect. But once you have this kind of ideas, definitely you can suspect this atypical bacteria. So, once you suspect atypical bacteria, then before you try to prove it, then you can go for azithromycin or doxycycline or fluoroquinolone. Nowadays, there are some reports reveal that there is emerging resistance against azithromycin. Nowadays, Mycoplasma pneumonia simply responds to doxy alone. So these are very peculiar features of atypical bacteria. So when you suspect atypical bacteria, you just advocate these drugs before you evaluate further. Then we have received one more case who presented with weakness of all 4 limbs. So weakness of all 4 limbs generally in the presence of normal consciousness, then probably you have to think of 2 possibilities. One, hypokalemia, and second one, GBS syndrome. This case has been admitted just hours before. Once evaluation is over, then I will keep you updated. Yesterday I told you one more case of anemia. We are suspecting hemolysis. That patient has family history of anemia and peripheral smear revealed there are spirochetes in the smear. So we are suspecting hereditary spherocytosis. We have sent the blood for osmotic fragility. Once results come, I will keep you updated and I will explain. Then one more case we received with fever and tachypnea, and there was hypotension around 70 mmHg. So I was informed that patient was entering into septic shock. But before you label to have septic shock, it is a rule that patient has to be resuscitated with crystalloid, especially 0.9% normal saline, 30 ml per kg. So in that case, the patient is weighing about 70 kg, so 70 into 30, almost 2100 ml. So first this patient has to be resuscitated with 2 liters of 0.9% saline. Then even after resuscitation of 2 liters of saline over a period of 2 hours, still BP is not picking up. If patient warrants noradrenaline to enhance blood pressure as inotrope, then probably you can say patient is entering into septic shock. So before any patient is labeled to have septic shock, patient has to be resuscitated with 0.9% saline, 30 ml per kg. But generally if BP is around 70, better to initially resuscitate with 0.9% normal saline, which will replete your intravascular compartment with 250 ml for every 1 liter infused. So we consider 0.9% saline as the fluid of choice in resuscitation of shock. Once BP picks up around 90, then IV fluid normal saline should be switched over to balanced solution, something like ringer lactate or plasmolite, which contains additional acetate or lactate, which can give rise to bicarbonate. So it can correct acidosis, which has been commonly associated with sepsis. But normal saline doesn't contain any substance which will give rise to alkali. So it won't correct acidosis. So it will correct generally blood pressure only. So any patient who presents with hypotension in sepsis, you try to lift up blood pressure with normal saline initially. Once BP comes around 90 to 100, switch over to balanced solution, something like ringer lactate and plasmolite. Thank you.